Good morning, everybody. Welcome to Pediatric Grand Rounds. Thanks to you who are in the room with us eating our donuts today, and the many of you who are on WebEx. Just a reminder, as usual, for our WebEx participants, make sure you're muted during the presentation, but if you have any questions or comments at any time, feel free to write them in the chat box. I will see them and share them with our speaker at the end of the presentation. And for now, I will turn things over to Dr. Tony Woodward to introduce our speaker for today. Thanks.
Thank you, Suzanne, and boy, am I excited this morning. This is awesome. Each year we have an annual emergency medicine conference on a Saturday, and our guest speaker from across the country comes in and speaks at Grand Rounds on Thursday, and we're really lucky to have Dr. Andrea Morrison here with us today. I have a prepared bio for Andrea, and I'll kind of skim through that a little bit, but Andrea is awesome. We know about Andrea. This is her first time, however, to Seattle Children's, so please treat her warmly. We're going to have a lot of time with her over the next few days, so we're going to have a great time. Anyway, Dr. Morrison is a pediatric emergency medicine physician and health literacy researcher and advocate. She completed medical school in North Dakota, internship at Nationwide Children's, residency at the University of Michigan, and fellowship in pediatric emergency medicine at the Children's Hospital of Wisconsin. She has additional training in research scholars, career development, QI, and advocacy. She currently practices pediatric emergency medicine at North Valley Emergency Services at Banner Health in Phoenix. She is the founder and CEO of Communicate Health, a health communication consulting company. Her vision is to transform healthcare communication to help children and families understand and make decisions about their health, including caring for chronic illness, when to seek emergency care, and appropriately dosing medications. In her former role as the medical director of health literacy, she spearheaded health literacy quality efforts at a system-wide level. She now consults organizations on health literacy, organizational improvement, reviews medical and research documents for health literacy, and continues to lead work in communication research, organizational improvement, and teaching medical professionals. So please welcome Dr. Morrison for our talk today.
Thank you for that warm welcome. The weather wasn't so warm and welcoming this morning, but you all have been very wonderful. It was 70 in Phoenix and sunny, so anyone who wants to come visit me, please do. I'm really excited to be here today to talk about some of our work in becoming a health literate organization. And most of the work that I'm going to talk about today was work that I've done at Children's Wisconsin and since continued to consult with since I've left, as well as some other hospitals. So our objectives today are I want you to be able to understand the impact of health literacy on health outcomes, and then evaluate some ongoing health literacy focused organizational efforts, and learn how you might create system-based strategies to improve organizational health literacy. So to start, I'm going to tell you about a couple of my patients, and these are actually patients that I had, and why we think that communication and health literacy is important for safety, quality, and equity. So for instance, a family misunderstanding how to give their daughter a home medication after a surgery and gives a 10 times overdose. And this is oxycodone and the child is 6 months old. And they ended up in the ICU because they misunderstood and gave a 10 times overdose. A mother returns to our ED just simply because she doesn't know how to unclamp the G-tube in order to give that first nightly feeding after leaving the hospital. And that ends up in an ED visit. Or a grandparent that doesn't know how to manage a life-threatening emergency with her grandson's trach and ends up having devastating brain injury because of it. These are real issues where communication didn't happen where it should have, and we really need to think about how we can affect this as an organization. So if we look at a couple of different definitions, one I'm going to first start talking about is personal health literacy. So that's an individual's ability to find, understand, and use health information. So it encompasses more than just reading, because people often think literacy, that just means reading, right? But it doesn't. It's more than that. It's being able to actually find that information-seeking ability, taking that information and use that to make decisions. And in the case of children, it's often parents for themselves, or for their children rather than for themselves, that they're making those choices. So how big of a problem is this? So I'm going to show you a couple of different maps. And I have to say, understanding the Seattle metro area on a map is a little difficult. I think it's in this picture. So if we look at the map that's on the left-hand side of the screen, we'll see that there are 4 different colors: green, light green, orange, and red. Red and orange being the 2 lower levels of health literacy. And we can see that there are areas where that tends to congregate and coalesce in different areas. And if we look at the map on the right, that was actually an adult language test that was administered to the population last time in 2003, and red being below basic and green being above basic. So we can see there are some areas where that kind of congregates. And the reason why is that health literacy is one of those factors that goes along with a lot of the other sociodemographic factors that are associated with health equity: race, ethnicity, culture, educational attainment, poverty, and really a lot of these are of poverty. If their primary language is other than English, geographic and environmental factors. We also have to think about experiences that they're bringing in, perhaps from their family or siblings that are teaching them things. And then age, which is a little bit bimodal, so younger parents tend to have lower health literacy, and then older adults tend to have lower health literacy. But what I'm going to show you is that if we look at this from the perspective of a distressed community index, which is one way of looking at some factors of poverty, we look at that map on the left, we see those distressed communities are in that maroon color and orange are at risk. And we see some of these areas really are coinciding with those orange and red on our map on the right. And so we see that those factors all kind of coalesce together with our distressed communities and with low health literacy. So this is a really big factor that we need to be thinking about when we're thinking about health equity. So why does it matter? Besides what I've already told you, and you might expect, is that health literacy affects health outcomes. We have known since 1998 that adults with low health literacy have more ED visits and hospitalizations. We have a very large body of data to show that they have more medication errors if they have low health literacy, worse overall health, higher mortality rates, more missed appointments and less preventative care, and higher healthcare costs on the order of hundreds of billions of dollars. And so this is a huge area that we need to be considering when we're thinking about how to affect health outcomes. And I put the citation for this paper on the bottom, and I want this to sink in just for a second. We've had data since 1999. There was a report from the Committee on Health Literacy for the American Medical Association that recognized the importance of health literacy. And in this paper, their quote was, "Health literacy is a stronger predictor of health outcomes than race, ethnicity, income, or employment." That means a lot of the data that I will share with you in the next slide has all been adjusted for race, ethnicity, income, not always education, because that is so highly tied to health literacy, but we're adjusting for that and still seeing health literacy as a large factor in health outcomes. So if you want to read more about it, I really suggest a review paper that we did for Pediatrics in Review a few years ago that really combines all of that research that's out there and available. This is just a very small table of the things that we found within the literature, and this is all pediatric literature. So the impacts of low health literacy are across health knowledge, behaviors, and outcomes. And what we find is that those that have lower health literacy have less topic-related knowledge. So that could be about their child's disease. It could be about general child care. They perceive their child to be more ill. Worse health behaviors, such as safety behaviors, like setting your water heater to 120 degrees or having smoke detectors in the home. Also worse feeding, nutrition, healthy weight, and tobacco and alcohol behaviors. And those behaviors of tobacco and alcohol are in adolescence that we measured health literacy in. Increased violent behavior, incorrect medication use, and we're talking about large overdoses of over 20% or underdoses in parents that have low health literacy. Also not understanding the interval for which they should be giving the medications or the indications why they should be giving over-the-counter medications. And then worse disease management overall, which has really been documented across diabetes, asthma, and nephrotic syndrome. There's a number of different diseases where it shows this. And health outcomes, including greater prevalence of disease, worse child disease-specific outcomes like hospitalizations in children with asthma, greater healthcare utilization, and that's across chronic and not children that are otherwise healthy, and then worse healthcare access. So you can see this is broad, cross-cutting, and a lot of issues in child health that are affected by a low health literacy. And as I said before in the previous slide, these are all taking into account also race, ethnicity, income, and sometimes insurance status. So it's no wonder that Healthy People 2030 goals they have addressed it before in the past in 2020 goals, but the new 2030 goals really elevate health literacy to the level of an overarching goal and a foundational principle. So there are not many of these are overarching goals and foundational principles, and there's a lot within Healthy People 2030. But the overarching goal is to eliminate health disparities, achieve health equity, and attain health literacy to improve the health and well-being of all. So you can see how the Healthy People understands that this is really interwoven with health equity. And achieving health and well-being requires eliminating health disparities, achieving health equity, and attaining health literacy. So we know that it is a very important factor in health outcomes, but the question is then, what can we do about it? Now, I'm not here to tell you what to do. If you want, come to a workshop on Saturday and we'll talk about it. But what I'm here to tell you is we have a lot of strategies that we can use. There are some that are disease specific, and then there are some that are broad. In our Pediatrics in Review article is also a fantastic place to go to look at some of those recommended communication strategies that we recommend using in a universal way. So screening for health literacy isn't necessarily part of what we should do for every patient. Rather, what we should do is universal precautions using these communication techniques with all. The reason why is people, even with adequate health literacy, they also benefit from this. So where do we come into play as an organization? And I think this lays out nicely how important it is that we are part of this equation. So if we look starting on the left, we have a family with a child that comes to us and they have their skills and abilities. Rather than looking at this as a deficit, let's look at what skills they have, what abilities they have, the love for their child, the care that they have, and the patience that they have. And we come in with our health system and we say, here's all of these things, here's all of the problems, here's all the things that we're going to do. How we present it to them, how clear we are and when we present it, really impacts what that equation and what health outcomes we're going to get because of it. So we need to be really conscious of our part of this equation. And that has come into play with a focus on becoming health literacy focused organizations. This is a definition from Healthy People 2030. The idea of this has been around since 2010. The first paper coming out about that in 2012 with some attributes I'll share. But this idea has been around for a long time, but the definition was updated with 2030, saying that it's how we as an organization equitably enable individuals to find, understand, and use information and services to make their decisions. So how are we doing this? With some foundations you can see on the bottom of this diagram that are our 10 attributes. I'm going to show you a slide of the 10 attributes. It's a lot, I know. I encourage you, if you're interested in it, just search for 10 attributes of a health literate organization. But it's across many factors, including leadership, planning, including health literacy and planning and evaluation and safety and quality, preparing our workforce, including our populations that we serve in the design and implementation, meeting the needs of our population that we serve, and then using health literacy strategies in interpersonal communications, providing easy to understand and access health information. The content that we provide should be easy to understand. And addressing health literacy in high-risk situations, communicating clearly what a health plan covers. So you can see this goes from leadership to how we communicate with staff to what we do in high-risk situations. So as an organization, we took this and looked at within our health literacy task force. So we have this health literacy task force at Children's Wisconsin that existed as a special interest group since 2006, and I took over as co-chair in 2013. And we sat down, and please do not think that you need to read this, but I want to demonstrate a couple things with this. That we sat down and really thought about what we had done and recognized that we made a very big effort at getting leadership involved. So number one on the top of the secondary key drivers. We worked to prepare the workforce. We did a lot of workforce education. We were trying to catch all nursing units. When I came on board, we started to touch different sections of physicians. But we really lacked in some of the other pieces of what we were doing of the attributes, such as making sure to include populations served, to communicate health health insurance information, and high-risk situations. So we really took the ideas of the 10 attributes, looked at what we had done, and looked what we needed to address to come up with future interventions that we wanted to do. And so I think anybody who wants to do improvement work within the area of health literacy, using those attributes to look at what has been done, and where can we go, helps you spread out across all of the different areas that need to be touched from an organization. And one of the things that this helped us understand is we really wanted to address health literacy in high-risk situations. We talked about it. We said there's lots of literature, and it's surprising how sometimes that is not enough to move the needle. And sometimes you need local data. So we decided to get local data. And this is a really fantastic example of having the right people in the right place at the right time with the right idea. And we had a nurse that had been on our health literacy SIG for, I think at this time, 10 years, and who was in our patient safety department, as well as my co-director who was in the patient safety department. And so we decided that we wanted to embark on a study to look at our patient safety events. So why? Why is that so important? Well, first of all, I gave some case examples in the beginning of things that are safety events that occurred. And we know in the realm of safety that communication errors are the top factor, and it's an up to 70% of adverse events. We know that not exchanging information can have tragic consequences. But what's interesting about the communication category is that it's broad. So it's interprofessional communication as well as us to the patients and families. And oftentimes, the interventions that have been developed for the safety category have been specifically to our interprofessional communication. Our safety training focused on that, and a lot of the training in the literature focuses on that rather than focusing on how we're doing communicating. And so that's why we embarked on this project for a couple of different reasons. With our goal to describe the impact of health literate communication on patient safety, and also to give us themes and ideas of where we should prioritize our safety practices. What we did was we used our safety event database, which all hospitals have one. Ours is called MIDAS. And we tagged those events or put a specific marker on them that they were for health literacy. Just like when you put an event, you probably choose, yes, this was an IV medication error or this was such an error. Health literacy just became one of those. And then we queried the database after we had been doing that. We did it 3 months at a time, up to 9 months where we had saturation, and completed a qualitative analysis. The qualitative analysis involved 3 members, and we adjudicated everything to make sure that they were all health literacy events, and then to decide where they fit into the different themes. So importantly, and this is not meant to be quantitative, but just to give you an idea of how many events there were in comparison, to over time, that approximately 4 times a week at least, there was a health literacy safety event that occurred. So we know safety reporting in general is the tip of the iceberg, and we also know that we have not stressed the need to put in those type of things. How many times have you ever put in an event where someone uses the wrong inhaler and they ended up in the ER because they were using their Flovent instead of your albuterol? Never. But somebody didn't teach them how to use it and they ended up in the ER. So these, at least 4 times a week, we're having health literacy safety events. And in broad looking at these themes, we broke them down into medication-related events, which isn't surprising because medication is such a frequent thing that is put into a safety event database. Discharge or transition was about 1/4 of them. And then health system processes that I'll talk a little bit more about, but it's the idea of navigating our health system. So what is a health literacy related medication event? The definition that we came to is it exists when a health system staff or care provider doesn't provide or ensure effective communication occurred with patient, family, or family member guardian when seeking medication information or providing medication information. That is a very long definition, but it actually isn't even long enough because what is effective communication? We actually adopted, JCAHO has a definition of effective communication that we used as part of that, which really means the back and forth of information. So what kind of events were there? So number one, we saw a number of events with medication reconciliation on admission to the hospital. For instance, patients receiving double a medication dose for over a week while inpatient because they're unclear medication history taking on admission. Or unclear discharge medication instructions. For instance, and this was definitely not a single case, it's kind of all together, but a lot of seizure medication errors where an increase or a decrease is planned over several weeks, and we have them going in different directions, and it may be different on the bottle. But for instance, one time mom used the bottle that was at home, and she just kept on that dose that she had, and didn't use instructions, and it wasn't clear what she should be using for an increasing dose, and they ended up back in the hospital. We had a lot of these events. Multiple conflicting instructions between the prescription bottle, our after visit summary, and then sometimes even other medication schedules, like a chemo medication schedule. And then we had some specific events around immunizations, which is its own sort of category, because there's a lot of different events, but they had to do with communication in a little bit different way, each of them. Now, what about these discharge transition events? So these events were things like unclear equipment information, unclear teaching about after visit needs, such as how to prepare for labs to be done after hospitalization. And sometimes that led to just a delay in actually getting the labs collected. And then unclear written information. So not understanding what their feeding regimen was or how they were supposed to obtain something, because it was unclear what they got for information. And then there's these health system processes events. And these are more like our navigation events. So unclear navigation assistance. So for instance, someone was having surgery, they had to have their blood drawn and a type-in screen was done, and then they needed to keep their blood band on for the next day. Well, mom had it in her purse, and she didn't know that it was supposed to be on the patient, and because it wasn't on the patient, they could not have the surgery. And so these are things that we didn't tell them to do and ensure that our processes were being followed, because and how was a parent supposed to know that? And relying on parents for specific information. So there are a number of different events where we were asking the parents rather than looking in the medical record to really understand, and led to unreliable information that we probably shouldn't be expecting parents to necessarily know. And failing to address a language barrier, I think, is a really big one that we've looked at also in different ways other than in this study. But an infant given a UTI prescription once a day and didn't get clear instructions and ended up giving it twice a day, it finished too early, and they're back in the ED with a febrile UTI and were admitted. So making sure that we use our interpreters when we need them. So what did this help us do for our improvement planning? Well, it helped us to prioritize efforts around organizational improvement. And I'll talk a bit later about medication safety that really specifically came out of this, because medication was such a high area of health literacy events. But it also helped us to be able to think about how we might improve reporting of these events and how we might actually do that in the database, which actually just happened finally this last year with an upgrade in the database, including branching themes and not actually using the word health literacy. We specifically are using words like communicating with patients and families. And then developing performance standards. So how would somebody take this information that we know from the health literacy safety events and apply it to improvement practices? So we developed performance standards both for medications and immunizations, as well as a broad-based kind of performance standards, using some other standards that were available in the literature. And then collaborative opportunities with other institutions. So we've collaborated with Nationwide Children's to help look at this from their perspective as well, use our data definitions to then apply to their data, and learn eventually, hopefully, to work on continuously improving together and learning from each other on areas where we can improve on this. So one other piece of safety that became important in the last few years, our healthcare acquired conditions. So these are the conditions of interest that are reported by multiple institutions, and working with Solutions for Patient Safety, large cross-institutional learning collaborative. So we looked at these specifically starting in spring 2022 as we had increasing healthcare acquired conditions in our hospitals, and quality measures were becoming worse through the hospital. And we thought to ourselves, well, what can we do on this from a safety perspective, with health literacy from a safety perspective? So we started to look at our data, and we did this in two different ways. One of the first things we did some qualitative work with our health literacy task force, and then the second thing is actually doing quantitative work, looking at the data itself. And what we first did with our health literacy task force is to look at what were the current HAC interventions that we were currently doing across SPS and in our hospital which included putting the head of the bed up, oral hygiene, changing the circuit, daily discussion, and where are the health literacy factors that might play into this? So if we're looking at the quantitative data, why might health literacy be important? And in our health literacy task force, we have a broad group of parents, a number of parents of children with chronic illness who have been in the ICU. We have people from our patient education department. We have lots of nurses, respiratory therapists, nutritionists. So why might it be different? So clinical observation may not be the same in a parent with low health literacy. They may not notify a nurse at a time when they maybe had that opportunity to notice a change. And sometimes parents feel like in the ICU, it's not their job. How much do parents understand about the care and the bundle elements and why? How much are we actually talking to them about that? A lot of times, and I heard this from a number of parents with chronic illness, the nurse does the nurse things, the parent does the parent things, and is not actively looking to do those nurse things. And it's difficult to ask questions during rounds, and they're not having the discussion that perhaps they need to. They feel pressure, they don't want to hold up the team. So here are some reasons why this might exist. And in fact, we did find a difference when we looked at the quantitative data. So we asked a health literacy screening question in the emergency department and in all hospitalized children. It's not perfect, but it is there. And we looked at that question versus these unplanned extubations and found that there is if we look at the unplanned extubations in the far right column, and that's per 1,000 ventilator days. Those that are low in their health literacy had 0.82 unplanned extubations per 1,000 ventilator days, and those that had adequate health literacy, which is the bottom all of the time, it's 0.43. And this is a significant difference. So those parents that have low health literacy, their child is more likely to have an unplanned extubation at nearly twice the rate of those that have adequate health literacy. And so one of the things that we did then with our task force is, well, what are those things that our HAC group could work on? And some of the things may include a pictogram that doesn't actually use any words. So that actually goes across culture, and there are some pictograms that have to be tested in multiple cultures to make sure that they still pertain to them. Ensuring that the head of the bed is up. That's something a parent can look for. It's easy, it's attainable, and they might be putting the head down. So because they think their child would be more comfortable that way. Including parent representatives on the HAC work team, which they had in the past and sort of faded away during COVID. So this is one of those practices that kind of got changed through COVID and never got changed back. And then talking about what are different behaviors on rounds that we might more involve families, may actually discuss with families ahead of time what rounds are, and clearly defining the why to parents, reframing them as partners in safety, rather than in saying, like, keep in your parent rule. So these are a few of our safety pieces that we've learned to grow from the safety events that we looked at. Now, kind of along the same time, if we go back to our key driver diagram and thinking about where we need to distribute our work, one of the other pieces that came into place was additional staff training. So one staff area we hadn't reached actually was our primary care clinics in any strong way. And they actually came to us looking for help for health literacy training as part of their patient-centered medical home designation. And let me tell you, it is a huge difference when someone comes to you asking for something rather than you trying to push it forward. And we had a lot of buy-in across 25 primary care clinics, and their staff did a lot of the training once we trained them, which was a fantastic way for us to really distribute this widely. So 475 staff participated in the training that we did across physicians. You can see in the diagram to the right, physicians, customer service, office staff, medical assistants, nurses, clinic leaders, APPs. And you may be thinking, well, office staff, I don't understand. But they're an important part of how patients are perceiving our offices to be, how welcoming they are, and they may not be able to, frankly, even read, much less understand some of the information that we ask for. So how we did this is we started out with a survey before we even started, and then we did a basic training module. So the basic training was online, interactive module with questions as part of that. And then after they completed it, they got an email, a boost email, we called it, 2 days later, which asked them to reflect on one thing that they took away and could put into practice. And then we did booster sessions that were in-person training And we actually did these as sort of like a quiz show. So it was kind of question and answer. People worked as teams. People really got into it. And some of the staff that were administering these sessions said that, there was some good healthy discussion about it while this was happening. So these were really great interactive sessions. And then we did a post-training survey. We, through the following year then, continued to sustain the efforts with leadership doing presentation on it, health literacy strategies as a flyer, doing a couple of lunch and learn events, and then rounding by the clinical practice coordinator, and then did a survey post-training 1 year. So if we look at, first just looking at the awareness, the columns in green are pre-training, blue post-training, so that's that kind of 4 month, and then the yellow is 1 year post-training. The asterisk just means that they're significantly different than pre-training. And so if we look at people understanding just the health literacy term, that improved after training, what it meant for patients if they had low health literacy, the health outcomes, and then knowing if patients understand. All of those improved after our training. And then our health literacy techniques. So interestingly, one of the techniques is plain language, so trying to use jargon-free language. And that actually didn't improve much, and it was probably because they were already doing it. That was probably the most, that was the highest level on the pre-training of what people were performing. One of the aspects is limiting the use of forms, and increased after post-training but didn't sustain to 1 year. Limiting information, which is one of the other principles, checking for understanding, also known as teach back, and then confidence in using those techniques. All of those had some degree of improvement post-training as well as a sustained to 1 year post intervention. So not only did this help our clinics, obviously, and we actually learned a lot too from some qualitative comments about where they had used them and those kind of things, but we know that we improved staff knowledge, behaviors, and confidence. But importantly, we found something within our learning environment, a technique in how we can do this, that then we can also apply to other work that we're doing. And so we felt, there was multiple things that we accomplished from this, but one of them that we really took away is we can use this in other ways too. So one other big intervention that we did over the last 10 years, I worked on this a long time actually, for asthma education, was improving our health literacy focus of our asthma education at Children's Wisconsin. So what does that mean? How do we improve the focus of our education? And I'm not just talking about our written information, because again, we often think about that. That's like the most important thing is our written information, but we did optimize that. So the techniques we use for written information are limiting information. So not giving every possible thing, but limiting it to the things that they need to know, giving explicit action-oriented instructions, chunking information, and that could be within a single handout versus we actually made a booklet, so within the booklet it's chunked into different places, using plain language and greater white space. And then we contracted for videos using a company called Booster Shot Media, who demonstrated a lot of things through videos. And you can see over on the handout that's on the right, there's some descriptions of the airways there, and you can see that there's like muscle bands around there that tighten down. And what we did is in the videos, these were actually all demonstrated in the videos interactively. It was whiteboard drawings while he was doing them. But then we took those screenshots, so everything was coordinated, and the language was all coordinated between the videos and the written information, so that we weren't using quick relief inhaler somewhere and like fast acting inhaler another place, so it was all the same language. And then also the pictures. And so that really, giving the video information along with the written information really solidifies the learning. But one important piece that we often forget about with patient education is how are we telling our staff to do this? And what opportunities are we giving them to have the tools to be able to do this? So as part of teaching them about the new asthma education curriculum, we also taught them about a few techniques how to teach and when it might be important in asthma. And so we used open-ended questions, talked about using open-ended questions, what teach back looks like, and maybe even when you should do it and what you should do it for. And when we moved into inpatient, we actually gave them specific teach back questions to use. The use of plain language limiting information, and then action-oriented information. In the ED, one of the things we really talked about was timing for medications after discharge as being something really important that our callback nurses were frequently clarifying. So we developed the education and worked on the teaching of this with the global aim of improving the value and equity of asthma care under our system-wide asthma team, and with the goal of increasing the proportion of children and families receiving asthma educational intervention, including video, written, and verbal education, when the child was seen in the hospital or in the ED for asthma exacerbation. So we are focusing also on those that were having an active problem, rather than doing this at a time when they may be more passive. So they're coming in for that exacerbation and they're getting this information. So the details of, my intent is not to show you the details of what we did, but more of why health literacy, doing our education from a health literacy perspective is important. But both in the hospital and in the emergency department, we increased our videos. So written information was given a decent amount of time, and we did increase that, but the videos were pretty impressive. So if we look at the y-axis is percent and the x-axis is time, and this is the percent of parents receiving video asthma education. And what we see with the improvements we made, we went from 0% to 33%, which was pretty sustained until, if any of you remember, December of 2019 with RSV and flu. That was like our highest ED volume ever before, the next RSV surge. And then COVID came. And so we did see some degradation of our data at that point. And we can talk more about that, but, COVID really did wreak havoc on a lot of quality work. So we also did this work in the hospital. And I'm showing you rehospitalizations and how we decreased hospitalizations. And this is both the data from the ED and the hospital. So again, on the y-axis, we have percent of discharges that were readmitted in a year, and on the x-axis is time. And we see the time points that are marked. So first we have time point A. That was when we finished our ED implementation. And then points B, C, and D is when they started the hospital implementation. And so we can see that there was a large drop-off after our ED implementation, because a lot of our hospitalized patients are coming from our emergency department, so they would have been getting that education in the ED. And then after hospital implementation, from 11% down to 3%. Now, the hard part about this is that, I think the reality is probably somewhere around like 6 to 8%, is that COVID changes really impacted asthma, right? All of a sudden we had no asthma patients. And so I think after, March of 2020, it's really hard to say, what effect our intervention had on this. But before that, we had seen some decrease in our rehospitalizations. So because of some of that, as well as wanting to control for other factors, I went back and did a retrospective analysis of the data just so we could understand it a little bit better, comparing groups with versus without the educational intervention, so with written, with video versus not. And we used generalized estimating equations that adjusted for age, race, ethnicity, preferred language, health literacy, and insurance status using backward selection. Now, let me just say, though, that those are all from the medical record. So age is accurate, yes. Race and ethnicity is the way we ask it. It's not always consistent, and sometimes it's just literally judgment based on the registration person. So that isn't necessarily the most accurate, clearly. Their preferred language is pretty accurate, and insurance status would be accurate. And so what we found when we look at this, and these are forest plots, with 1 being not significant. If that bar crosses 1 at all, it would be not significant. So this is the effect of written education on return visits, either to the ED or hospital. And what we found is that they have less return visits in 1 year if the parent received written asthma education, either with the outcome of ED or hospital. 0.82 is our point estimate, and then the bars are the confidence interval. If they return to the ED, it's 0.83, and if it's hospitalization, return visit for hospitalization, it's 0.72. So all of these were decreased. This model was specifically adjusted for child age and insurance. Race, ethnicity, preferred language, health literacy were all not selected into the model. Child age and insurance, though, being very important factors. And then again, this is video, and it's the exact same type of graph where if the confidence interval crosses 1, it would be not significant. So these are all significant for all those return visits, that the children have less return visits in 1 year if they receive video. So both video and written were effective, and they were effective across age and insurance status. So from this, we really realized that, first of all, it's effective, right? And I think a couple of the different factors that make it really effective, because sometimes people are pretty astounded by this data. They're like, well, education doesn't work that well. From a health literacy and education research, let me tell you, it does, but you have to do it right. A couple of the things that we did was that we specifically focused on health literacy when we were both designing and rolling it out. It was also given at that time where a parent is actively thinking about their child's asthma because they're in the ED or hospital. So they had a negative outcome, and so they're more keyed into learning because of it. Also, standardized information has benefits for staff and for families. We did not have standardization of our asthma education inpatient or in the ED. There's not something that was always given. I also standardized our discharge instructions along with this. But one of the interesting things inpatient, and this is sort of that qualitative stuff that comes from doing this work, was that nurses felt like I knew what to teach because we had bundles that they taught, and they knew that they should teach the first bundle within the first 12 hours and the second bundle within the second 12 hours. And then they had teach back questions that they could use. And the nurses, like when our COO was doing rounds, they said to him, that's one of the best things that happened this year was this asthma education. So standardizing some of this information actually really has an impact on our staff too. And from this, we really know that these interventions can impact outcomes on an organizational scale. There are a lot of tricky things to sustaining this effort, COVID just being one of them, but technology changes were also a really big piece of that because this wasn't something that our hospital did. This wasn't a process that we already had, and so sustaining some of the technology was tricky. So I think that asthma is a great example of how we can improve organizational health literacy to provide health equity, but I want to kind of talk about the ideas behind how we could do this and how you might think about approaching this. So when we think about health equity and trying to achieve that goal or grabbing that apple from the tree, people need different help in order to get to that health outcome goal. But there are some things that are equivalent treatment that aids everyone, and there are some people who need extra steps to help them get there, giving us our foundational pieces and our step-up pieces of what we might need to do in specific interventions. So what could a foundation look like? A foundation can look like leadership support of clear communication. So this makes a huge difference when we have that foundation of leadership supporting all of this. Integrating health literacy and health equity into quality and operation activities. You might notice these are a lot like the 10 attributes because they are. So we organize these in how we would see the 10 attributes work for equity. Our health literacy staff and provider training, low literacy written materials and forms, our discharge instructions needing to be low literacy, including things like pictographic medication instructions and universal medication schedules, which are known to reduce errors, both in dosing and in timing, and providing clear health system navigation. All of these things are going to help everyone. They're going to help everyone achieve better health outcomes. But what could be those things that we might do in work in health equity or specific to a disease or improvement process that we're trying to do? We can use specific multimedia low literacy education materials. So thinking about the asthma study, we made specific materials for that particular disease state to help get that extra boost that they may need, and the disease or situation specific health literacy needs. I'll talk about a medication example next that kind of focuses on that. And then things like shared decision-making modules, also pieces like navigators, coaches, advocates, coordinators of care. And that has definitely been expanding in our health system. I mean that health system nationwide, from insurance companies, from different places. And so that is a huge help for people that have low health literacy, to have those people on their side. So what could this look like? And I'm going to present this as more of a work in progress, although it's been a work in progress for a lot of years, but it still is, about how we decided that we wanted to approach medication safety. So what does that look like? And our goal was to decrease these medication harm events across the care continuum. And I don't just mean those that were labeled health literacy, I mean all harm events. So the first thing we need to do is improve our staff discharge medication instruction across the care continuum. The second, decreasing parent medication administration errors, but that includes giving them information that's more accessible and usable. And then equitably to do this, to decrease the medication harm events, for parents of children, or of children of parents with low health literacy. So when we think about a lot of work in safety, we think about bundles, and I think this is a really great way to think about this. So if we go to that left-hand graphic, we see that there's sort of a standard risk and a high risk. And though I have people there, I don't mean people, I mean situations. So parents who have low health literacy, that's one factor. And these are all things that we are taking into consideration, speak a language or prefer a language other than English, greater than 2 medications, or new medications, over 5 medications, and then, of course, low health literacy is one of those factors. So taking into account all of those things, there are some situations that are more high risk, and we need to do more for them. So a standard bundle could apply across all, and that includes improving our staff education and our written education. But then we have high intensity pieces that are needed for those that we can identify as being at a higher risk for medication misunderstanding. So the standard bundle, clear verbal medication communication, providing staff and provider training. So what we did was we developed a very similar training process as to what we did in primary care, where we had an online module and then in person, well, they ended up being on Zoom, training, different Q&A training modules. So, and this was done, we did this work both in the ED in our ambulatory surgery areas. And then we measured afterwards, the effects of the training. But instead of just general health literacy training, which is what we did in the outpatient clinics, we actually did this training specific to medications. There are a lot of medication techniques that are health literacy related, very evidence-based, founded in research, that are effective. And so these are things, including how we talk about medications, how we might talk about taking it twice a day, that are very nuanced and specific. And so that's what our training was focused on, was medication, not necessarily just health literacy. And then our other goal was to provide a clear written medication communication. So doing our verbal education and improving our written education. And what we used was an electronic health record add-on called Meducation that provides pictograms, medication schedules, and I have 20 languages on here, but I think they keep adding. I think it's like 45 now. And while it was wonderful and did all the things that we wanted it to do, it was still an add-on. And so people didn't use it. And that's one of the real struggles that we had with this, is getting people to use this add-on. I get it, like doing extra clicks when you're already in a rushed ED, it's difficult. But what this could provide was pictograms, which reduce dosing errors by over 20%, which is like a syringe filled with volume up to the level of what the patient's dose is. And then a universal medication schedule gives a dose on 4 times a daily dosing, arranges all their medications like that, and it improves adherence. So those are very well founded in research, but until it really gets integrated in the medical record, I think we'll struggle with that. And then things like a standardized communication checklist. So what could be those high intensity bundles? So still we've focused on trying to identify who those high risk situations might be, but then we can focus our limited resources, like the pharmacy bringing medications to the bedside and doing bedside teaching, even in the emergency department potentially, after visit follow-up phone calls, intensive case management support, education materials. There are a lot of other pieces that could go into that high intensity bundle and might depend on the area of the hospital. So this is more of a work in progress. I didn't show data because it's not all that great, and it's still a work in progress. But I think it's important to think about how this could be done, and you can think about how you might do something in a goal that you're trying to do using some of these same principles. One other piece I just want to share is that there is grant funding available for this. We did write for an R01, we did not get it, but the AHRQ has put out a special emphasis notice on research into improving organizational health literacy to prevent and manage chronic disease. And so I think especially from some outpatient settings that are focused on specific diseases, there definitely is some funding. They use the same definition, very similar anyway, to Healthy People 2030 for their organizational health literacy. And then the last thing on there is just talking about what they're looking for in the grant funding. Could be training, could be policies and processes, could be implementing evidence-based approaches. So there's a lot of different factors that they're looking at as part of the training or as part of the grant. So I'm going to close with a few things I want you to think about is that we can improve our equity, quality, safety, and experience of our care we can do this even by our awareness. We can start to think about this as part of quality efforts that we do, our current practice. We can work on this on a local level, where we work, where our clinic is, where our hospital unit is. And we can do this on a system-wide level, which is going to have the greatest impact once we can do this across systems. And think about how issues or improvement that you are trying to make, a health literacy perspective might help. It might help understand part of the root cause. It might help you obtain a goal that you haven't been able to. And I really want you to think about health literacy as a factor or a piece in our work to provide health equity. It's something we can do as a hospital that can provide that improved healthcare outcomes for those who really need it. And I'm going to leave you with some words from the grandmother of health literacy, Rima Rudd. We don't take information as seriously as we should in healthcare. Words can be as important as drugs. We should be prescribing good information. And I'll leave it there. Thanks so much.
Wow. Thank you so much, Dr. Morrison. Really, really important for all of us providing care. I'll open things up to questions in the room first. If you have a question, you need to use a microphone so that all our WebEx providers can hear you. And if you're on WebEx, feel free to type a question and I'll read it out for you. Thanks.
Andrew, that was great. Excuse me. It's very compelling as you go through this in a very organized fashion. What were your challenges before you had all this data to convince your leadership that this was important? How did you work through those kind of processes?
Yeah, sometimes when people present quality things, it also seems easy, and we have to remember this is work of 14 years. Like, this is not a short amount of time. And I think one of the important things that we tried to do was to get our leadership on board, and going to our CMO / chief safety officer, he was both at the time, at kind of the beginning of when I took over our health literacy SIG, asking for the support, them as our administrative kind of liaison and support. And I think that was the first stop, because then we could start talking at different forums and talking to other leaders and kind of have that window into what we needed. One helpful thing was I actually brought a Grand Round speaker in 2015, which actually really helped a lot, somebody who had done organizational health literacy work. And I think that opened a lot of eyes to the work that could be done. And then I think one of the also, not only getting buy-in, people think that they're doing a good job educating. They think that they're doing a good job talking to patients, and don't want to admit that it's not, what we're doing is not right. And so I think that was a huge struggle to overcome. And I think with time and persistence, people more and more were understanding of why this was important. But it still wasn't a big organizational priority. So it was still just sort of an add-on, tack-on. And the other strategy I think that we used is that we tried to work along with organizational initiatives. So when we were doing our safety event review, safety was very important in our organization, as it always has been, but I think there was an additional boost, additional safety training that was ongoing, that we kind of latched onto the work that was happening. Again, asthma education, while it was something I had been working on, we had then a system-wide asthma team established that helped some with moving that forward. So I think trying to work within, rather than trying to even just do your own work, really helps to move it forward, because you're adding to work that's everybody's already focused and working on.
Thank you. A few questions from online, and then I'll get you. From Casey Lyon, thanks for a great talk. I'd love to hear more about how you have tackled the challenges related to making these written resource improvements available across languages.
So languages is a hard one to address, and I don't know what your current requirements are, but over 5% of your population, you have to provide written resources in the language, meaning in Children's Wisconsin, the only one we were required to provide written information was Spanish. So I think it gets more challenging in in areas that are more racially diverse than, say, like Children's Wisconsin was, because then that bar is a lot of different ones. So, and I think it's a struggle between providing what you feel like is the best information that may be the most local, opinion-based sometimes in medicine, rather than using like a standardized national vendor. Because there haven't been great standardized national vendors. So I don't know if you all use CRAMES, but CRAMES traditionally has not been very health literate. It's much too long, has a lot of jargon in there still. But the benefit is that it can provide it in multiple languages. So I think you kind of have to weigh the balance, the pluses and minuses of vendor, where we get this information that is in multiple languages, and we aren't trying to provide those translation versus like what is the quality of the information. So there is a product that we had looked at using at Children's Wisconsin Kids Health, which is from DuPont, and they have patient instructions actually that you can add on to the EMR, but they only have English, Spanish, and Arabic the last time I looked. But I think working with a vendor to provide standardized information, that version is very much quality. They focus on health literacy principles, is important, and I think is probably easier than doing on an individual level. Because what we did at our hospital for our discharge instructions, for instance, is we'd write them in English, they'd be translated in Spanish, and then there was a lot of epic work that happened in the back end to make that happen. So when you can use a standardized vendor, and then encourage them to change, encourage them to improve, encourage them to be, or push them, I should say, instead of encourage, push your vendors to be providing information in multiple languages so that you are getting what you need from them.
Sorry, I wanted to piggyback on Tony's questions. Thanks for this great talk. Yeah. So did you get funding help or anything? Because you mentioned that there was an asthma team and then the pharmacist coming to the bed to go over the instructions. Like, these are extra hands that we need. And with post-COVID era, the hospital struggling with budget and everything, how challenging is it to convince your leadership, because this is going to need some extra funding?
I didn't mean to make it sound rosy. Our funding was not rosy. I was unfunded for most of these years of doing this work, other than my academic funding. So because it's my passion, that's why I spent a lot of time doing it, but I didn't actually have a funded position until I think 2020. So I did a lot of years without any funding. My co-director, who's in patient safety, could do it as part of her work, but she was expected to do all of her other work. And she took on this huge medication safety project and didn't have any time to do it. She finally now has a funded position now that I'm unfortunately gone, but we worked for that for a lot of years. But I think I pushed for just myself having funding probably for 5 years before I got funding. So, I mean, that's unfortunately the reality of it. I think like the meds to beds, for instance, that was something that our pharmacy was providing from our outpatient pharmacy, trying to use resources that are there and then focus them in on areas where you might need it most was kind of what our mantra was, like trying to use the resources that we might have. And the asthma education work, no funding for that, no, none, zero. So I did get a grant to fund the videos. So like a local grant to fund the videos, which were like $10,000. But other than that, like there was no funding to do the work, unfortunately.
So the leadership was okay coming on when we need extra money, and like that's one of the things that they would ask.
What do you mean, the extra money? Like the
for these projects, you need some extra funding. So leadership would think of those things before coming on board. So is there a way to convince them, or?
I think start doing them, right? I mean, like if you've already started doing them, and then they know that there's some proof of concept there that you are able to do it, or do it in one venue that then you could do it in another venue. I think funding is extremely tricky, and making your case is always going to be the best way to obtain funding, whether that's from grant funding or whether it's from an organization. But making your case either from local data, from previous work that you've done, is always probably a great way. I mean, I definitely do not have a magic answer for that, and I would love to hear if anybody does.
Thank you so much. I will just point everyone who's online to some resources in the chat. We have some of our quality and health literacy leaders who are putting links. We do actually have some patient education on child. So please take a look at that. If you're on WebEx, you can click the link, and if not, I can get it to you if you're in the room. And we're out of time, so thank you so much, Dr. Morrison, for all your expertise. Thanks, everyone, for being here, and we'll see you all next week.